afternoon. Our topic is about how to interpret a meta-analysis. These are our main objectives. Just we will take the most important points. First, meta-analysis is part of evidence-based medicine, which incorporates clinical judgment, patient values, and preferences with relevant scientific evidence. There are hierarchical classification of the level of evidence. At the top, we have systematic reviews and the meta-analysis. Here, lower levels are from RCTs, cohort studies, observational, and other types of studies. The first thing we have to know is what is the main difference between a systematic review and a literature review or a narrative review. A literature review is selective. The author of the review picks up whatever he thinks is important for his subject. It is selective, and this is the main problem. Sometimes we call it a narrative review or a journalistic type of review. Systematic review is different. It is not selective. You have to put certain criteria at first. You have to define a question, put certain criteria for the studies, and formulate the search methodology to address 4 points: the population you are working on, the intervention, the comparator against which you compare the intervention, the outcomes you are going to evaluate. What are the advantages or merits of a systematic review? Systematic nature of the review implies that the search methodology is predefined, transparent, and reproducible. Whoever wants to make the same search again, he will get almost the same results. That means it is reproducible. This helps minimize the bias in the results or the overall or the conclusion of the review. Now, what is the difference between a meta-analysis and a systematic review? A meta-analysis is a step farther beyond the systematic review. The main aim of a meta-analysis is to combine or pool the results from several independent studies to produce an estimate or a numerical value for the difference between the intervention and the comparator. It is, therefore, we call it quantitative synthesis. The direction and magnitude of this effect size or difference, together with the precision with which we estimate it, that's it. Sometimes we call it the confidence, constitutes the end point of the meta-analysis. So what are you expected to see in the results section? On the left side, we have the basic points we'll try to address, and if there is time, we'll address these more advanced points. This is an example from a meta-analysis we did before on the value of ST segment new changes in the ECG, and it's a relation with major adverse cardiac events after non-cardiac surgery. The first thing you will see is the Prisma flow chart. This describes how you went through the search. There are 4 phases: the identification, screening, eligibility, identification, and inclusion of the studies. Here we got how many studies from the basal search, then you remove the duplicate studies, then you screen studies by title and abstract, then you remove whatever you think is not relevant, then you have to go full search, you read the articles you think important, then you exclude some, then finally you get these studies for the systematic review or the qualitative synthesis. If there is adequate data, you will include in this meta-analysis or quantitative synthesis. The second thing you have to see is the characteristics of included studies. Usually you include some table summarizing the studies. Here, for example, the 8 studies, the design, cohort, or retrospective, and type of surgery, and other things you think important. How we evaluate the risk of bias or methodology, I mean methodological bias. According to the type of the study, for each type there is specific tools to apply to the study to determine if it has a high possibility of bias or low possibility. For RCTs, randomized studies, we have this Cochrane-Robb risk of bias tools. For non-randomized studies, we have this Robin's I or Roban. For if you are evaluating the accuracy of a diagnostic test, you will have this QUADAS, and it is It's a new version, the Quadas 2. This is another example from another study we did also. Here, after you assess the bias, you get these figures. Here, you evaluate each study, and you apply the 6 items of this was RCT. We used the ROP tool to identify the risk of bias. The red means these items are missing. There is possibility of bias. The yellow means it's unclear. The green, it's passed. It's okay, no bias. Overall, you combine the studies here for the overall quality of the research itself. The green means overall 50% is low risk, and about 30% there is high risk of bias, and these are gray area. This is another study about some intervention comparing. The studies were non-randomized. We applied the ROP in the eye. So here, this is a little different. The items will not be the same like ROP study of the Cochrane, because there are, for example, there is no randomization here. So this item is not applied. It made up of 7 domains. The green means it's okay, the yellow questionable, and this is high risk. This is a study for evaluation of ultrasound as a substitute for CT in critically ill patients. Here we use the Quadas because we are evaluating diagnostic accuracy of a test, DTA. The Quadas is different. It is composed of 14 items applied to the studies, and we see if it is fulfilled or not. The green means this one is very high quality study. This one is questionable, for example. Overall, you combine the search from this same study. The green areas means it is okay. The yellow areas, it's unclear. The red is high risk. Now, what is an effect size? We read also this term. The effect size is simply the difference between the comparator and the control. According to this, the type of the outcome, if it is a continuous outcome like arterial blood pressure or IOP, or it is binary outcome like survival, death or survival. Here we present the outcome as mean difference or a standardized mean difference. Mean difference, SMD, is the same like this divided by SD. We use it when each study uses a different unit or a tool for measurement of the outcome. We use this. For binary outcome, we express the outcome measure as odds ratio, risk ratio, or risk difference. Here is for continuous studies, we MD. What's important is the null value. When it is equal to 0, means there is no difference. The ratios, the default value or the null value is 1. Sometimes we put the odds ratio as log for scaling purpose only. The log of 1 is 0, so the null value is 0. For ratio, risk ratio, the null value is 1. Or if we are taking the log, it will be 0. Risk difference is 0. The default value is 0. The second most important thing, or actually it is the most important in the meta-analysis, is the forest plot. This summarizes the effect size. This is a study was on evaluation of the role of hypothermia post-arrest on survival and neurological outcome. Here, this is the forest plot. Each study, you put the odds ratio for each study, lower and upper limits of the confidence limits of this odds ratio. Here, each study is represented by a small box. The box is related to the size of the study or the weight. The bigger studies take higher weight, smaller studies take smaller weight. Then overall, you combine here with this diamond-like sign. This tells you the odds ratio is 0.81 and ranging from 0.68 to 0.97. It is statistically significant. This is for the same study was for a neurological outcome. It is also here. The diamond is shifted below 1. If it is shifted below 1, it favors the intervention. The point we want to know is the pooling. In meta-analysis, we do what's called pooling. We combine the studies in a pooling, not in simple algebraic summation. The pooling is based on the weight of the study or the size of the study. The higher studies take higher weight, smaller studies take smaller weight. Heterogeneity is another term we want to know here. This determines how the studies are variably reporting effect size from each other. There are measures for the size of heterogeneity. The most important is the I-square. This ranges from 0% to 100%. The higher, the more heterogeneity. This, for example, this study shows I-square 78. This is very high. There is much heterogeneity. If you look at the plot, you will see that each study is going somewhere different from each other. This also is I-square 91%. So there is marked heterogeneity. The same study, but here for this outcome, the heterogeneity is low. For this, heterogeneity is high. What is the value of heterogeneity? The importance of heterogeneity is that if we have marked heterogeneity, we should use what we call random effect model for pooling of the studies. This determines how we are going to pool the studies. If there is no heterogeneity, we use a fixed effect model. This is a statistical issue. How to deal with it? We sometimes, this is the same study, sometimes if there is heterogeneity, we want to know what is the source of heterogeneity. We pool studies, common studies with each other. This studies used fluoroscopy, this studies used CT. So there is marked difference between the pooling of this and pooling of this. The blue is the overall pooling. This is another study from pooling RCTs alone, then non-RCTs alone, then overall pooling. Sometimes we do what we call sensitivity analysis or leave one out analysis. Here we sequentially remove each study and see the overall effect size, if it will change or not. If you observe here, when we remove this study, we got a marked difference in, so this study is maybe a source of heterogeneity. All these 5 studies in red had different estimation. This also from our study, this sometimes if there is heterogeneity, we do meta-regression. Meta-regression, we evaluate the age or any other factor that may be responsible for the heterogeneity. Here we rest the effect size on the age, and we found actually there is marked association between age and the effect size. The higher the age, the lower the effect size we got. So this may explain the heterogeneity in the studies. Publication bias is very important. Publication bias means that there are studies that are banned from publication because they are reporting negative results or no statistically significant difference. That's why we have to test for it, because if there is publication bias, this means there reduces the level of evidence. How we examine it, we use this plot, we call it funnel plot. We plot each study against the standard error of the study, which is a measure of the size. So small studies will be here and large studies will be here. If you find a part of this triangle trimmed out, this means you have publication. This one shows you this half of the funnel is missing. This means there is publication bias. This the same like the previous one, but we call precision plot. It will give the same result, but here we don't plot the standard error, we plot the inverse of the standard error. This will give exactly the same result. This study we did also here, there is publication bias. We try to correct it using what we call trim and fill. These two scientists, Duval and Tweedy, invented this method. They see how the funnel is asymmetrical, and they try to make it symmetrical with virtual studies. These one are added, they are not real studies. Then they recalculate the effect size here. So they correct the effect size here will be corrected from here. This is some correction. This is something also from Duval and Tweedy. Here 5 studies are missing, so there is publication bias. We put it 5 virtual studies and recalculated the effect size. It was shifted or reduced. Beyond meta-analysis, after meta-analysis, we have to evaluate the overall level of evidence. Is it high or low or moderate according to this scale or grading system? this is the grid system. Here, 1 minute. The grid system takes into consideration, for example, for this outcome, if are items that these items reduce the level of evidence, and after all, the pooling will be like this. The conclusion is very low evidence, even you have get statistically significant results, but the overall evidence is low. This is at last a few words about network meta-analysis. When you do multiple comparisons from multiple studies, you can do indirect comparisons between different interventions. This is an advanced type you may come across. At last, here, this Dr. Paul is one of the most eminent in this field. He put this quotation that the physician who can't read a paper in the 21st century is like one that can't measure a blood pressure or examine the cardiovascular system. Thank you.